last time we met, on Wednesday, regarding cancer. What do you think are some important things that you as a generalist nurse need to know if you're dealing with a cancer patient? From stuff we talked about on Wednesday.
You have a higher chance of getting bladder cancer from smoking.
Okay, smoking definitely a high risk factor. What are some other risk factors?
Workplace environment.
Okay, environment, so chemicals, toxins. Diet is a big one.
Obesity.
What do you say?
Obesity.
Obesity, especially with like breast cancer, stomach cancers. What's another big one? Alcohol, stress, okay? Sometimes just bad luck. What are some other things that stuck out? Do you guys think are important to know?
It can present in really different ways than you would expect.
Okay. What were some of those things to watch for that were on that slide that just said cancer? Fatigue's a big one. Changes in what?
Weight.
Bowel or bladder habits.
Weight.
Weight, yep, so unintentional weight loss. Some cancers, like if you have a huge tumor in your abdomen and they get a lot of fluid or ascites, might have extreme weight gain. I've seen patients with certain types of tumors that put off tons and tons of fluid and they look like they're 9 months pregnant walking around. It's really just this huge tumor in their abdomen that grows really rapidly. Some lymphomas can do that as well. So it could be weight gain in that situation, okay? What were other things on there?
Infection that doesn't heal.
What?
Wound or infection that doesn't heal.
Okay, a wound or infection or scratch or something that doesn't heal. Moles that change, obviously that's more skin cancer related. Any lumps, bumps that shouldn't be there, that magically appear. A change in condition over a certain period of time, okay? So we talked a little bit about the psychosocial component, psychological component. Obviously that's huge. Anybody going through cancer, they lose a lot of sense of control. When we get done talking about cancer, you guys are gonna listen to 2 guest speakers who've gone through it themselves. And one of the hardest things is kind of that loss of control. Having to be at appointments when people tell them to be there. Having to eat certain things or not be able to eat certain things, right? We all want control over our own lives, and when you lose that control, it's very, very hard. Okay? Another thing with people who have cancer, when I was in Omaha and worked in this world, we had a salon specific for our cancer patients, and the cosmetologist who ran it had cancer herself. Her mom died of cancer, her sister died of cancer, so she had a very personal connection, and she would always tell patients the best day in their life is a day that they're not thinking about cancer. So it's constantly kind of this weight on their shoulders once they've been diagnosed that lasts their whole entire life, right? When they think about my next birthday, they're thinking, am I gonna be alive for my next birthday or my kid's birthday? Or will I see these milestones in life, right? So they definitely have a different perspective on life once they've been told those words, you have cancer. And their families will have a definitely different perspective. And sometimes it's based on history, so maybe their neighbor had cancer, went and got diagnosed, had chemo, and died the next day. I have seen that happen, or sometimes it's so bad and you try to kill it and it literally shuts their body down and they die very suddenly. So if somebody had or knew someone with that experience, what is their view of cancer going to be like? Very grim, right? They might be one that absolutely refuses to need treatment because of an experience that happened to somebody else. Okay, so the psychosocial is very huge. Lots of body image things psychosocially. If you think about like breast cancer, women losing their breasts, sometimes that's very hard for them. If they lose their hair with chemotherapy, I've had patients that have adamantly refused to do the treatment they need to do because they don't want to lose their hair. Like if you think your hair is a big part of a lot of who you are, even some males, I've had male patients that are like, I'm not losing my hair because it's a very big part of who they are. So body image can be a huge thing. There's lots of different things out there. There's cryo caps where basically they wear this like bonnet on their head that the idea is it freezes their scalp while they're getting chemo, so it basically kind of shuts off the hair follicles So the idea is they won't lose their hair. Some oncologists are against it because if you're giving chemotherapy and then it doesn't reach that scalp, there's been patients that have actually gotten meds, so cancer has spread to that area because chemo never reached that area because of this cold cap. And it's not 100% effective. But you might hear of these kind of cold caps. It's kind of a newer thing, probably within the last 5 years, that some patients will use for hair loss. Some childhood considerations are across the lifespan. What do you think probably are the top cancers that kids get? Leukemia is a big one. ALL, acute lymphocytic leukemia. You guys don't necessarily need to know what it is, but leukemia is a big one. Also, brain cancers. There's a lot of kids that are prone to getting brain tumors, and then cancer of their bones. So like sarcoma, Ewing sarcoma is a big one, where they get these super large tumors that grow inside a bone, very, very painful. A lot of times they have to amputate above where the tumor is because it's a very aggressive, spreads very quickly. So if you think of a child or a teen or adolescent and you have to get your leg amputated, the psychosocial component that goes with that, pretty severe, right? But that's what they might have to go through to save their life. So obviously they have a little bit different psychosocial needs. A lot relies on the parents. Kids are pretty resilient. They don't have this fear of death, right? If you guys got told you had cancer and you had 2 years to live, you would be thinking about death probably more than living, right? That would be a huge impact of, oh my gosh, I'm gonna die. Where kids don't really have this fear of death, right? They don't develop that until later on, probably in more teen, even young adult years. They just don't have that fear of like something terrible is gonna happen to me. They really don't know, so they're pretty resilient going through it. It's the parents that obviously struggle a lot more. So in most cancer centers for like kids, if they're gonna do anything that's painful, so like accessing their portacath, drawing blood, if they have to do any sort of procedure, they have a specific procedure room where kind of that child can relate, okay, all bad things happen in this room. Because they want their hospital room to remain kind of a safe environment for them so that they're not terrified when they drive to the castle to get their treatment. They're so scared to go in, or they don't want to give them like PTSD from a childhood cancer. So they'll have like a room that they can relate, like, okay, if I go in this room, I know something bad is happening in there, which could be a bad thing, but they'll also sometimes not have the parents be in the room if something painful, so the kid doesn't relate it to the parent and think negatively of their parent. Depends on the child. Makes sense? So a lot of different kind of psychosocial things. So what is kind of things you guys need to do as nurses if you're caring for somebody with cancer, caring with kids with cancer? What are some things that you think are priority of things I told you? What do you guys think?
Keep like a routine of things.
Okay, routine might be important. Educate them as much as you can, right? Give them as much knowledge. If you're dealing with a kid, you have to kind of focus on what is the whole family dynamic, okay? Do they have siblings? How are their siblings being affected? Because if you have a child that has to go through all these treatments, and what if they have 3 younger siblings, and now mom or dad are no longer in the picture for months on end because they're dealing with this child. So the siblings really play a role too. Or if it's an older sibling, they might have to kind of take on more of a parent role while their younger sibling's getting treated, right? And then nutrition is a big one we'll talk about, because remember I said they need at least 2,000 extra calories when they're going through treatment to help their body heal, to help fight it. Often they're not hungry, nothing tastes good, especially if they're going through chemotherapy. Chemo makes everything taste like metallic-y, or a lot of patients will say it tastes like cardboard. I've had patients who go through radiation, they say everything tastes super salty, so nothing tastes good, so then it's hard to say, well, you need 2,000 extra calories, but they can't even drink water, right? So nutrition's a big one. Just some statistics on childhood cancers. These are from 2020. The numbers aren't that different depending on where you look. So if you ever have somebody that wants to know where to get good, solid information regarding cancer, so maybe they have a new diagnosis, and they say, where do I look up? The American Cancer Society and the National Cancer Institute really are the best ones, so it's either cancer.org or cancer.gov. Those are gonna give them the most legitimate numbers as far as statistics, prognosis, treatment. Those are really the most legit websites. The Mayo Clinic has some good stuff too, but sometimes it's specific to what they do there. So those are two really good places you can send people. So, some stats, these are from 2020, I just looked at them this morning, and one site said 10,500 children in 2022 were diagnosed, so not a huge significance. Another site said 15,000, so about 5,000 more cases. But then you have to think, is the world's population increasing? Is it decreasing? Is that why cases are going up? Are more kids? For children, it's been about consistent numbers for a long time. The biggest thing is more kids are surviving. So years ago, it used to be they had about a 58% of 5-year survival, and now it's about 85% chance. So the odds are pretty good for kids with cancer, 85%. Okay, but what about the 15% that don't survive? That's still an issue, right? So there's still obviously a problem with kids. Here's kind of the most common types of cancers. So leukemia, brain is probably the most deadly, but there are kids that survive brain tumors. Neuroblastoma, so affects like the neuro system. Wilms tumor, you guys, we talked about that in assessment. Remember what a Wilms tumor is, where it starts? In your kidney. Your NCLEX book will tell you if you feel something there, don't palpate hard because you potentially can spread that. I don't 100% believe that to be true. It's probably already spread. I don't think you can actually puncture a tumor just by palpation. But Wilms tumors are pretty common. NCLEX loves that question. So if you see a Wilms tumor, don't palpate that area. It usually happens on the kidney. They can usually remove it and go on. Now you can get lymphomas. This is more teenage years. After kids go through puberty, they're more prone to get lymphoma. So lymphoma is a cancer of the lymphatic system, where it's considered a blood cancer, but mostly the lymph nodes are affected. So kids will present with like huge tumor like coming out of their neck or like in their armpit, and it usually comes on pretty aggressive. Both are pretty curable in kids. Here's some other ones. Retinal is obviously of the eye. Retinoblastoma, remember in assessment what they look like. What you'll see if you took a picture of a kid, and if they had a retinoblastoma, what their eye would look like around their pupil. They have like a white kind of halo around their pupil, classic sign of a retinoblastoma. And then Ewing sarcoma is pretty common in like teenagers. Very, very painful and very, very aggressive cancer. You guys don't really need to memorize these. But what do you think you would educate someone about signs and symptoms for childhood cancers, or any of these up here? What do you guys think? If a parent said, how do I know if my kid has cancer? What would you respond to them as a nurse? What do you think would be signs and symptoms? Probably depends on where it is, right? So if a kid has an acute leukemia, bone pain is a huge one. Now sometimes that's hard because as kids are growing, they can naturally get kind of bone pains, but this is like an intense pain, where kids are crying, they can't go to sleep, their legs hurt, their back hurt. Classic sign of leukemia. Nosebleeds, huge. They have a nosebleed, they can't get to stop. Why? What's happening? Their platelets are low, right? So these leukemias, these blood cancers, they eat away the normal healthy blood cells, so that's why they don't have any platelets. So bleeding is a huge risk. Any lumps or bumps that don't heal. If they have petechiae, what's petechiae? You guys have heard this term before, I believe. It looks like a rash, it looks like little red, kind of flat, on the skin. It's basically when capillaries break on the surface. It's called petechiae, P-E-T-E-C-H-I-A, petechiae. So a very common symptom, or bruise, if they bruise really easily. So basically any signs, the same signs and symptoms you'd see if somebody has decreased or low platelets, right? Or don't have any platelets to clot. So bleeding, bruising, this rash on their skin. Night sweats is a huge one with lymphomas and leukemias. If they're like drenching their blankets or sheets at night, or they wake up and their pajamas are literally drenched in sweat, classic sign. Why do you think that is? What's the process that's happening? Why are they sweating through their sheets? I said this on Wednesday. What's the difference between cancer cells and normal cells? Rapidly dividing, right? They are multiplying and mutating 3 to 4 times faster than your body's normal cells. So what is that doing to their metabolism? Woo, revving it way up high, right? The body inside is working very, very fast to either try to realize, hey, there's something abnormal going on here, and they're also having a lot of cell division on a cancer level going on in their body. So that causes night sweats. Another classic sign. Okay? Also, if they don't meet any of developmental milestones, so maybe they go in for their checkup and their height is not increasing, or their weight's not increasing. They might need to say, hey, is there something else going on? Okay? Again, with kids, just like adults, it's not always these textbook signs and symptoms. Cancer is a unique beast with a mind of its own. But kids are a little more textbook than adults for sure, just because our bodies compensate a lot differently, okay? So kids who've had treatment of cancer, so we're gonna talk about radiation therapy in a little bit, they can have some long-term effects from the treatment itself. Because if you're treating a kid who's 6 or 10, what should normally be happening with this body? They should be developing pretty quickly, right? Their bones are growing, their muscles are growing. So if we are putting poison in their body to kill their cancer, what are we doing to their normal development? We're gonna screw it up, right? If kids get radiation, so if they have to have bone radiated or chest radiation, if they have a bunch of big, huge lymph nodes with like a lymphoma, they can potentially have heart problems down the road. They can have lung toxicity. They can have development issues. If they got certain chemotherapies, they can have heart problems. A lot of chemos are cardiotoxic, meaning it's toxic to the heart. It's literally poison we're putting in their body. What is that gonna do to your blood system? What is it gonna do to your heart? So cardiomyopathy happens long term, and it can be years after they've had their therapy. I had a girl come and talk once that she had a Wilms tumor as a kid, and then when she was in her 20s, she was a nurse. She is a nurse. She's still living. In her 20s, she noticed she would get really short of breath, like walking upstairs or just walking short distances. And she was a very fit, very petite person, like smaller than Alexi. This girl is. Not to call you out, Lexi, but you're kind of petite. Okay, very small body because she got a lot of chemo, a lot of radiation from her Wilms tumor when she was a kid. She got it around age 6, I want to say. Okay, she's short of breath. She can't climb stairs. So she goes to the doctor, has this huge workup. Her ejection fraction of her heart was about 15%. So her heart really wasn't functioning. She was in congestive heart failure in her 20s from all this chemo that she had as a child to save her life. So she actually had a heart transplant in her 20s due to chemotherapy she had when she was young. She has a pretty fascinating story. She continues to work in the NICU as a nurse in Sioux Falls, so some of you might know her. But she works in the NICU because she can't lift patients, obviously. She can't do some of the demands that normal adult nursing takes. but she had a full-blown heart transplant. She will never have children because she's infertile from the radiation and chemo that she got. She will always have kind of a short bone structure, very petite build. Like she wears kids' clothes as a 20, 30-year-old adult because all of this treatment affected her bone growth, affected her ability to ever have children, and she has some hormone issues because her hormones never developed right. So just because we're doing things we have to do to treat them and cure them, there's a lot of long-term effects that can happen with kids and adults. If they got radiation to the head and neck, it can affect their thyroid, they can deal with hypothyroidism, which, okay, would you rather be living and take Synthroid or be dead, right? Risk and benefits. Cardiomyopathy is a big one. When we talk about the chemo drugs, we'll talk about kind of they have a lifetime dose, and once they reach that maximum dose, they can never have that drug again because it increases their risk of damage to the heart. They can also get a secondary cancer later in life. So anytime we're putting chemo into somebody's body, we're actually increasing their risk of a secondary cancer developing. Okay, pregnant women. So I have given chemo to pregnant women. They have to be more selective, obviously, of what they're getting. They don't ever give it in the first trimester because we know that's when most of the development is occurring with that fetus. So sometimes they'll try to get the mom as far along as she can, as safe as she can, and then they'll give them chemo. But they can get chemotherapy. Diagnosis might be delayed. This happens a lot. There's a lot of women who have gotten breast cancer while they're pregnant. Why do you guys think that is? The rush of those hormones, right? Your hormones change when you become pregnant. So a lot of breast cancers are estrogen positive, meaning that estrogen in their body feeds this cancer. So you become pregnant, you get more estrogen, right? Increases your risk of getting breast cancer. And a lot of times they'll say, oh, I felt changes in my breast, or I have breast pain, or there's drainage, and docs will kind of poo-poo it off, well, it's just from the pregnancy, or it's from hormone changes. So sometimes a diagnosis happens late. I took care of a lady in her 30s, had her first baby. She kept complaining, I feel something in my breast, like I feel something. No, it's from the pregnancy, it's from the pregnancy. Guess what? She was diagnosed with stage 4 cancer after she delivered her baby. Because she was ignored, and she died about 2 years later. Very, very sad when she had a 2-year-old at home. So diagnosis can sometimes be delayed. Treatment obviously is a little more complex because you have to deal with the safety of the baby. So they'll do surgery if they can, but again, surgery is not always safe for somebody who's pregnant as well. They can use certain types of chemo, okay? So obviously it's very much a team approach. A lot of collaboration happens when you're dealing with anyone with cancer. You're gonna have hopefully a dietitian. Sometimes they have speech therapy, so if somebody's getting treatment to the head and neck, they will have like speech, do swallowing studies, they might have ENT on their case. So obviously a lot of different entities go into place. The client needs to be actively involved in their care. So I think one of the biggest takeaways, if you guys ever work in oncology or work with anyone going through cancer, let them run the show as much as they can. Because remember, one of the hardest things is them losing that control. So if you let them make some decisions, and they might make decisions that you don't agree with, it's their decision, right? Sometimes those choices are made out of fear, so we have to decide, okay, tell me more why you choose not to do any treatment at all. Maybe it's because they had a neighbor that did chemo and died 2 days later. And so to them, it's not worth it, okay? Maybe they are just really scared. Maybe they're scared of dying. So chaplains are another, obviously, resource we would use. Dietitians, they use a lot of caseworkers, social workers, because if you're going through treatment, you're gonna need at least probably 6 months without working. So if that person is the main financial person making the paycheck in the family, or what if you're a single mom, who's gonna pay your bills? Right? So a lot of decisions go into planning. Nutrition is a huge one, kind of hit on that already. So are they getting enough calories they need? Are they getting good calories? Usually we'll tell patients going through cancer, eat when you're hungry and eat what sounds good. Okay, and then what if you have somebody who's diabetic? They're like, well, I can't eat all these calories because of my sugar. We don't care about your diabetes right now, we care about your cancer. Like if you wanna battle this, treat it, you need to get as many calories as you can. Sometimes they need supplements like protein shakes or Ensure or Boost. Some patients will end up with a feeding tube. Some of you have met the lady from Parkston who has melanoma, right? It started in her abdomen. Some of you have accessed or de-accessed her port down there. She's a younger lady. When she said the worst thing out of all of this was when she had a feeding tube. That was just very, very hard for her when your family's sitting down to dinner and you have to put this nasty smelling, gross protein stuff into your abdomen and that's all you can eat, right? The psycho component of that was very, very hard for her. Okay, so nutrition can be a big part. So diagnosing, how do we know if somebody truly has cancer, okay? So sometimes we find things on x-ray. A lot of times things are found incidentally, meaning maybe they go in for some other surgery, they have a chest x-ray, and they find that they have a nodule in their lung. Okay, so x-ray, they'll use CAT scan for any solid organ tumors. So like if it's in the lung, the liver, stomach, any organ, you're gonna do a CAT scan. That's gonna give them the best image, right? If it's something in the bone or the brain, then they're gonna use MRI because it's gonna give them the best image. We'll sometimes use ultrasound. Nuclear imaging plays a big role in cancer treatment, especially PET scans. So PET, so maybe some of you guys in clinical have seen patients who had a PET scan. So this is a picture of somebody who has a PET scan. So if somebody has cancer, say they have a lung cancer, and they want to know what lymph nodes it has invaded into, or if any, okay? Because that's how we stage it, which we'll talk about in a little bit. So a CAT scan is black and white, right? And sometimes it's hard to differentiate, like, okay, this looks like a mass, there's some grain around it, but if they smoked for 20 years, and now they have a lung cancer, their chest x-ray might not look great anyway, right? Or their CT of their chest might be hard to really tell, is this a lymph node that's involved with cancer, or is this just some gray, fuzzy area because they've smoked and they have fibrosis, or they have damaged lungs or scarred lungs, right? So CT is not always the best scan, so we use what's called a PET scan, where they take a glucose substance, a nuclear medicine, so it's radioactive, and they inject it through an IV. The patient sits there for 1 hour and waits. They can't do any sort of like walking or exercise. They just want the body to absorb this glucose substance, okay? Because cancer cells like glucose, they like sugar. They will absorb it a lot faster than your body's normal cell, okay? So if you have a tumor somewhere, it's gonna suck up this substance faster than your body's other cells. And then when they look at the scan, they look at how lit up or how much uptake of this nuclear medicine these cells absorb, okay? So they'll call it uptake or the SUV of this. So then you'll see it lights up on the scan. So if you looked at this, then you can tell, okay, this person has tumor involvement here, they have it up here in their bronchioles, I have some lymph nodes over here, and then what's this right here? What do you guys think that is? Kidney maybe? Okay, they never use a PET scan for somebody's brain or their bladder. Why do you think that is? Because it's very active, right? Your brain is constantly active. Those cells are always active. So it doesn't give, it would give like a false positive. Your brain would always light up hot because it's more active, right? Same with the bladder. The bladder is very active, so it will absorb that substance as well, and it's gonna light up. But for any solid organ, lungs, kidneys, liver, it will light up the abdomen, and then they can tell, okay, this is exactly where we have lymph nodes, or this is exactly where we see this large tumor. So it's a better scan that patients will have. And it's kind of, so usually they'll start with a CT scan, and then they'll have them do a PET scan, especially if they suspect that it's spread somewhere else. Okay, they can do angiographs if they need to. Sometimes direct visualization, obviously if somebody presents and they have a large nodule coming out their forehead, like the guy told you about, they can suspect. They can do lab tests. So on some of your blood cancers, obviously their CBC is gonna be out of whack. If they have metastatic disease in one of their bones, we expect their calcium will be really high. So a CMP, there's also tumor markers that they can draw. So like prostate, the PSA, right? It's used as a tumor marker. If somebody has a really high PSA, good chance that person probably has prostate cancer. Okay, there's tumor markers for breast, for colon, ovarian cancer, that they can look at that marker and say, okay, it's super high, we suspect there's something going on there. Okay, so this gets more into staging of a cancer. So you guys have probably heard people, the general public, if they get cancer, they want to know what stage am I, right? So it's usually stage 0 to 4 or stage 1 through 4. So it depends on how invasive it is, if it's spread, and if there's any lymph nodes that are involved. So in the cancer world, they use what's called the TNM staging system. Okay? So TNM, the T stands for tumor, so how large the tumor is. And it's different based on what cancer they have. So for breast cancer, if somebody's tumor is greater than 2 centimeters, that makes it a bigger stage. They might have stage 2 versus stage 1. Okay, the N is the number of lymph nodes involved. So any sort of solid organ tumor, so breast, lung, liver, any cancers of the abdomen, stomach, bowel, rectal cancer, they're going to sample lymph nodes when they do the surgery. So if a woman finds a lump in her breast, goes in, has a mammogram, they say, yep, there's definitely something suspicious there. They're gonna go in and take a biopsy where they poke a needle in, they take this grabber looking tool, they grab tissue, they are awake when they do this, they give them some lidocaine. I've heard women say this is worse than childbirth or any pain they've ever experienced because they're going deep into tissue, taking a sample, they look at it under the microscope, yep, it looks like cancer. So now they have to go and test lymph nodes to see has it spread. Because the first place it's gonna spread is in lymph nodes, right? So if you have a breast cancer, it's gonna spread to the axillary area, to those lymph nodes, right? If you have rectal, abdominal cancer, prostate cancer, it's gonna spread to the lymph nodes within the groin area. Lung cancer, it's gonna spread to lymph nodes around your lungs. You have a lot of lymph nodes in your chest, and in like the bronchioles, it's gonna spread to those lymph nodes first. So they do a lymph node sampling. So based on the type of cancer, determines how many lymph nodes you need. So if somebody has breast cancer, they test what's called a sentinel lymph node, which they basically inject dye through the nipple, watch where that dye goes. If a lymph node sucks that dye up, that's called the sentinel lymph node. They'll remove just that lymph node, see if there's any cancer in that. They do that right before they go into surgery. If that lymph node's positive, they'll go and take some more around there to see do they have more lymph nodes or if it's just one, and that determines their treatment. Colon cancer, they need to test at least 20 lymph nodes to determine how much spread it is, how aggressive it is. So that's your N. And then the M in there, anyone guess? What would the M stand for? Metastasize. So have it spread outside of where it originally started, okay? So that's what the TNM staging system is for. So they stage them 1 through 4. So it's based on tumor size, number of lymph nodes involved, and has it spread to anywhere, okay? They'll also use grading system. So this is the lesser the grade, the less aggressive the cancer is. So this they base off of the pathologist looking at those cells, and they use kind of that cell differentiation. I kind of talked about this on Wednesday. So if the cell, say they take a sample from the breast, they look at it under the microscope, and it looks like a breast cell, but they can tell there's cancer on it. It would be more well differentiated, because it can still tell that it came from a breast cell, right? If it's poorly differentiated, then we know it's more aggressive, because it doesn't look like that original cell. So that kind of plays into what grade and classification. You guys don't necessarily need to know that. I'm not going to test you on like grading or classification, but if you ever hear people say, they said my tumor was poorly differentiated, what does that mean? That means that it's more aggressive, or they found it later than they should have, or they have a less prognosis. Okay? So they can also use cytological exam. So say you have somebody with this massive tumor in their lung, and to the point where they come in, they can't breathe, they're short of breath, they do an x-ray, and they have a big pleural effusion. So they have fluid that is surrounding their lung. So they do a thoracentesis, stick a needle in that, drain off that fluid. They're gonna send that fluid to lab and look at that to see, is there cancer cells in that fluid? That is cytology, okay? Same if somebody presented with huge ascites. So somebody has a big tumor sitting in their liver, eventually it's gonna shut that liver down or make it work really hard. That liver's gonna start pumping out fluid, and they will get ascites. So they do a paracentesis, test that fluid. If there's cancer cells in that, that is cytology, okay? So it's fluid coming from an area that shows cancer cells. Can also be used for diagnostics. If somebody presents with lung cancer and they already have cancer cells in the fluid, much worse prognosis. Their chance of survival is probably not great from the get-go, okay? Same with like, if somebody presents with ascites and they have any sort of abdominal tumor, prognosis is pretty crappy, because it's already advanced to the point where their body has to try to get rid of this fluid and it can't compensate anymore, okay? Makes sense? They can also use tumor markers, so they test like a CEA, CA19, PSA. Again, not something you guys are gonna be tested on, but sometimes patients will, if somebody's gone through treatment, they'll often use that tumor marker as a way to see, are they still in remission down the road, okay? So like if somebody's had breast cancer, went through treatment, instead of sending them through all these scans all the time, they can test their blood and say, okay, their CA19-9 is staying baseline, we're probably good. If it starts to elevate, then maybe their cancer is back. So you'll hear patients with cancer talking about their tumor markers. That's what they're referring to. Okay? So here's this, this kind of goes over in one slide kind of what I just told you guys about. So staging 1 through 4, the higher the number, the more it's spread. Anyone who has stage 4 cancer means it's already spread outside where it originally started. At that point, it is no longer curable in most cases. There is a couple exceptions, like somebody, if they have colon cancer and it's spread to the liver, they still have stage 4 colon cancer, but sometimes they can go in and cut out that little piece of the liver where it's spread. If they catch it soon enough, they can treat the colon cancer, they can do surgery on the liver, and sometimes they can still cure them. That's a rare case. Or lymphomas, if it's spread, lymphomas are diagnosed a lot differently. Basically, if they have lymphatic spread below the abdomen or below the diaphragm, it's a higher stage, versus if they just have maybe a large lymph node in their neck, or maybe lymph nodes in their axillary area, then they'd probably be like a stage 2, because they have 2 spots of lymphatic spread above the diaphragm. They're staged less. If it's above and below, then they're considered a stage 4. Or if it's their spleen is involved, then it's stage 4. So if somebody says to you, I have stage 4 lymphoma, then you know, okay, they have disease above and below the diaphragm, or they have spleen involvement, or both. So that's kind of a unique little entity. Leukemias are not really staged because it's a true blood cancer, so they don't stage those as much. And we'll talk about some other differences when we get there. So I'm not necessarily gonna test you guys over this, but it's good knowledge to know when you hear people say, oh, I have stage 3 cancer. Okay, well then you know that they have a larger tumor and they might have lymph node involvement that put them at stage 3. If they say they have stage 4, then you know that it has metastasized to another part of their body, which is why it's stage 4. Okay, so best case scenario obviously is stage 1. Or in breast cancer, if it hasn't invaded into the tissue and they just have cancer cells just kind of sitting on the surface, that's a stage 0, or called DCIS, which we'll talk about next week. Okay, so they can do surgery. A couple uses for surgery as far as treatment. So if the tumor has not spread, then they can go in and remove it. Best case scenario, right? You find a cancer, you want it gone. So for breast cancer, they will always choose to have surgery, either a lumpectomy or mastectomy. So either they remove the whole breast, mastectomy, or they just remove the lump, lumpectomy, okay? We'll talk about that more next week. Colon, they always do surgery to remove the portion of the colon that's affected. And then some lymph node sampling. Like I said, they have to have at least 20 lymph nodes to sample to get a true diagnosis and staging. If somebody has a tumor in their liver and it's confined to a certain area that's safe, sometimes they can remove it. Usually liver cancer, it's found too late and has taken up too much that they can't do surgery. Head and neck cancers, they'll always do surgery first, followed by radiation. Prostate, they'll remove the prostate. So they can use surgery to get the cancer out. If somebody has stage 4 cancer, it's already spread to other areas, they won't do surgery, okay? So say somebody, you have a female that goes in, they're complaining of back pain, they have some scans done, they have cancer sitting in their bones, and they biopsy that and it came from their breast. They're not gonna go and take that cancer out of their breast. Because why? It's already spread. You can remove it from the breast, you can take their breast, but they still have cancer floating around in their body. If it's already in their blood, it's probably already in their lymph system and their bloodstream. So it's gonna continue to spread until we do an intervention. Okay, so if somebody has stage 4, surgery is rarely used unless they need to use it for like debulking. So maybe you have a really large tumor that's sitting near a nerve and causing them a lot of nerve pain. Sometimes they will go in and debulk the tumor, so make it a little bit smaller just for more palliative care. So just to give the patient some comfort, but they're not doing surgery for a curative intent. Okay, if it's early stage, they take it out, that's for curative intent, okay? Why don't you guys take a break and we'll talk about meds. You guys are getting a little